Hi, my name is Mai Duong, and I'm a PhD student at the University of Sydney. I'm pleased to present our work on deprescribing heart failure medications in older people, a systematic review and meta-analysis. Heart failure is associated with high mortality and cause of hospitalization in older people. People are often mostly frail and living in the community. In addition to treatments of complex symptoms and comorbidities, heart failure guidelines recommend optimization of up to 4 drug classes, and most heart failure patients experience at least one adverse drug event. These are perceived to be mostly serious, which have a major consequence on their daily life and cause emotional distress. These people are 38% more likely to change a medication. However, deprescribing implementation and safety remains unclear. Therefore, we aim to evaluate the feasibility, clinical impacts, and outcomes by frailty status in older people who ceased or reduced the dose of a heart failure-specific medication. We did this through a systematic review using the PRISMA 2020 checklist and validated the search with the PRESS checklist. We found 4,700 studies through 8 databases, registry citations, and websites, and 2 independent reviewers screened all studies and eligibility for those over 50 diagnosed with heart failure, receiving treatment, and reported adverse withdrawal effects or outcomes and objective frailty measures. We found a total of 27 studies and included 5 randomized controlled trials of about 500 participants and 22 observational studies with about 400,000 participants. We assessed risk of bias using the Cochrane ROB2 and Robbins I and certainty of evidence using GRADE, and half of the extracted data was validated by a second reviewer. We performed a meta-analysis if heterogeneity was not substantial, with a Higgins I-squared less than 70%, and a meta-regression on study level factors if possible, and if not, we did a narrative analysis. So the randomized controlled trials showed that ceasing digoxin was feasible and remaining off of it, and reducing the dose of ACE inhibitors by 50% and remaining at that dose was also feasible. However, this was also associated with increased lapse of heart failure symptoms and hospitalization. On the other hand, observational studies reported lower feasibility, and increased harm was reported with high certainty for ceased digoxin and beta blockers. Crossover studies reported no hospitalization and less than 1% mortality, and no outcomes reported by frailty status. Therefore, we must balance the benefit and harms of whether to continue or deprescribe medications with changing patient priorities and disease progression. Further clinical trials and observational studies are needed to inform appropriate deprescribing in frail older people and guide shared decision-making. Thank you to my fabulous supervisors and collaborators and our team at The Calling. Thank you for listening.